So good afternoon, everyone. I'm your host for today's session, for today's webinar. My name is Agitiara from TDR Global Asia. Pleased to meet you all. It's a great and lovely Friday. Perhaps some of you are joining from the other side of the region. It's already afternoon, or perhaps it's midnight. Or if you're in Indonesia, Nepal, and India, good afternoon. It's very lovely, perhaps a bit sunny on July. Today, we're glad to introduce you that TDR Global Discovery once again had bring us a beautiful, lovely researcher. If you're a TDR member, you might perhaps very familiar with this platform. If you're looking for expert or guidance or uh, researchers requiring some additional exposure for your works, TDR Global Discovery Platform is a public database of people who have received funding, serve as expert on committees, and who have been involved in TDR partnerships over the last 40 years in our research and battling the poverty disease. So today we have our esteemed TDR Global member. We have Ms Aney Rijal. Uh, she is she and her team, perhaps if you have subscribed to our newsletter, perhaps you have read, she and her team had conducted a mixed method study across 3 point of entry help desk on the Nepal-India border to identify the barriers and facilitators in the following the protocols for malaria screening interventions. That paper is really great. If you haven't read it yet or you want to read it later, we have the QR code below. You can scan to read the full article with the QR on the left. And for QR in the right, you can also see her profile on TDR Global. So perhaps it's your time to pick up your phone and just scan a little, perhaps while you're listening and watching the webinar today. You can also enjoy her writing. It's very, very good and very informative to all of us. Her research clearly underscores urgent message of consistent resources and standard operating procedures. But we'll hear from her right on the spot right now. Ms. Aney Rijal, are you here?
Hello, good morning.
Good morning, everyone.
Thank you so much for having me here. Thank you for the great bio. So, as- I'm I'm Aney Rijal. So I'm from Nepal, and I'm currently working as qualitative research officer at Herd International. So particularly, we are focusing here at Herd specifically on building resilient health system and through the participatory action research. And so I'm the alumni of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia. So I will, throughout the session, I will be talking about my research, my thesis research that I had conducted during my postgraduate studies. Shall I begin, Agi?
Yes, the floor is
Okay.
yours.
Okay. So the title of the research is Exploring Barriers and Facilitators in Implementation Fidelity of Malaria Screening Intervention at Nepal-India Border Point of Entry Health Desk. Malaria is a vector-borne disease characterized as an acute febrile illness caused by the bite of a female Anopheles mosquitoes infected by Plasmodium species. It is endemic in 83 countries and areas and remains a significant public health concern globally, with an estimated 263 million cases and 597,000 deaths in 2023. So the WHO Southeast Asia region estimates 5.2 million cases, accounting for 2% burden of global malaria cases, and endemic in 9 countries. So India here alone accounts for a higher percentage, that is 65.7% of total malaria cases estimated in the region.
Annie,
Yeah.
perhaps you can reshare the presentation.
Okay.
So sorry.
Can you see?
It haven't on yet. Perhaps maybe you can reshare. Yes.
What can you see now?
Yeah. It's good.
The full screen?
Yeah, it's good.
Okay.
Thank you so much.
So Nepal shares the porous border with India. The porous border means that there are multiple entry points. Some are official, some are unofficial, and it poses the challenge for elimination of malaria to the country like Nepal, which shares its border with the country of like India, having high endemicity of malaria transmission. So border malaria refers to the transmission of malaria that occurs across or along border between countries sharing a land border. So graph, it shows the parasite spaces and the case classification from the year 2013 to 2023 of only of Nepal, and it shows that the imported malaria cases are somehow decreasing, but not decreasing in the same rate as the indigenous cases. And in the graph, we also find that the majority of Plasmodium falciparum infection, that is 97.36% of total imported cases, showed an increasing in trend, rising from 13.53% to 28.3% between 2020 to 2023. So majority of imported cases coming from returnees or migrant workers arriving from the state of Maharashtra and Gujarat, which are beyond the adjacent districts of India, and significantly contribute to malaria transmission, leading to a higher likelihood of local foci transmission. So, Nepal's National Malaria Strategic Plan emphasizes on malaria surveillance for outbreak response and prevention of re-establishment. And to eliminate the malaria cases in Nepal, the major activities was to intensify the malaria testing at border post, health facility, and including active case detection at community levels, targeting mobile migrant workers. COVID-19 pandemic, having shared risk of infections and common clinical signs and symptoms between COVID-19, HIV and TB and malaria, integrated testing was conducted at 13 point of entry Heldex of Nepal-India cross-border. So the interim guideline, which was brought upon in March 2021, so that's why there was the development of standard operating procedure, which is not yet published online, but then it was shared to the health workers working at the point of entry. This SOP was developed by the Epidemiology and Disease Control Division, which provides the step-by guidance to the health worker, and it involves the history screening, taking history screening treatment and follow for the migrants. So these are the 13 point of entry Heldex, which adjoins with India. And amidst the low cost effectiveness of the intervention, among others, it is important to understand how the protocols are being followed and what factors facilitates and hinders screening activities at point of entry. So the major objective of this research was to access the malaria screening intervention as per the available protocol, including barriers and facilitators in the point of entry Heldex at Nepal-India border, located in Sudur Pasim and Lumbini provinces. So, as I mentioned earlier, Sudur Pasim and Lumbini provinces, which lies in the far western and western region of Nepal. And in this study, we took 3 points of entry uh, from Kanchanpur district, Kailali district, and Baki district. Study design is concurrent mixed method, where the quantitative data, that is epidemiological records, were taken from the Sudurpaschim and Lumini province about the malaria cases and the malaria testing. Non-participatory observations were conducted among those point of entry health experts, and qualitative interviews were taken where we took 26 KIIs, 1 FGD, 7 client interviews, 8 follow-ups, telephone interviews. So as implementation research, we have to use the frameworks which will makes our life quite easier. So the implementation fidelity here is the degree to which an intervention program is implemented as it is proposed or as recommended in the approved protocol. So this study assesses the adherence and how it is moderating or creating what are those factors which is enabling or inhibiting the malaria screening interventions. So as I mentioned earlier, the quantitative data, we took the records, monthly malaria test and case data from Epidemiology and Disease Control Division from 2022-2022, register review from selected point of entries from March 2021 until December 2022, and descriptive analysis was done for those data and visualized in charts. So observations were done, especially the protocol adherence were accessed via standard operating procedure-based checklist. Qualitative data were taken where the interviews were taken with the health worker, officials, migrants, development partners, police officials. So those were recorded and the thematic transcribed and thematic analysis was done via QDA minor. And the triangulation of insights were done among the stakeholders. So this is the characteristics of study participants. As I mentioned earlier, the health worker of point of entry, epidemiology and disease control division focal person, local level municipality, province representative, health office, development partners or INGOs, migrants, and police officials were taken. So we didn't record the police officials interview because we hadn't taken the full approval from the administration. So we just recorded, we took the interview, but we just recorded or made the notes. So talking about the result, so the screening trend has the variation between the 3 point of entry, and the screening trend is consistent at Gadachoti point of entry, while 3-hour point of entry exhibited peaks in the late February 2022 until September 2022. And in contrast, Jamuna point of entry experienced few peaks, followed by decreased testing since September 2022, largely due to festivals, elections, and theft issues and other reasons. So the respondent reasoned that testing are intensified seasonally during the agricultural seasons and during the onset of rainy seasons, during the June until August. So as we observed in all 3 point of entry, and we found over there some inconsistencies, especially in terms of the having the availability of malaria testing protocols. The health worker were quite struggling to fulfill the health declaration forms, and they were not able to fully provide the information before testing, and there were some inconsistencies in terms of finger prick, and the way they were identifying the samples was not quite coherent, which was creating some confusions within the health workers. And they were not waiting fully for 20 minutes to identify the test results. which can cause some of the missing cases, some of the unsymptomatic cases would not be identified if they fully not follow the protocol. So the qualitative data here is divided. The results were divided into 4 themes. So the first theme is factors affecting the adherence to the protocol. So the health worker reported the unavailability of test kits, the workload and kit shortage affected full protocol adherence, and frequent stockouts and delayed procurement of malaria RDT kits from federal level. There was some perception gaps that the local level health workers, they were continually doing the screening as long as they don't have the shortage of test kits. While the federal officials cited that they were not able to conduct the testing that much because they perceived that the local level does not, I mean, the point of entry, they don't receive that much of suspected cases from the India going migrants. So there were inconsistent screening criteria, especially like as mentioned before, there's SOP which had mentioned the travel history, where they come from, but there were some varying. They were taking the migrant workers and screening with the varying histories and symptoms. Like the preference were mostly given to the Nepali migrants, but over the Indian daily cross-border travelers. And exemptions were also done for the groups like pilgrims and those without belongings and those by passing the police checks. So it directly links with the porosity of border that we mentioned before, like the unmonitored crossings borders are also over there, and there are inadequate infrastructures and human resources to fully equip those equip the screening facilities in those unofficial cross borders, and the risk-based prioritization was done due to the open border challenges. So here this quote mentioned that the obvious signs and symptoms were only tested, but they had to examine other migrants, and so the health worker they always have to be in rush because the migrant populations they are also in the rush, and uh, they are not able to fully adhere to the protocols. Point two is structural and service factor. So the availability of health worker over there, so it was quite limited, and the working hours were not available during the evening times, especially when the migrant population arrived to the destination and causing the missing migrants. So staff shortage and frequent absenteeisms was also found, and there were challenges in dealing with the dynamic migrant population, including exposures to the health risks. While some health workers they were quite demotivated due to the delayed payments, like especially they were not paying the paid with the allowances while working at that risk area. So the positive side was the health worker and police counseling migrant about the testing benefits, and the health worker were constantly sensitive towards the migrants about telling them about taking care of themselves and then do the testings. And but however, some of the migrants were quite abusive and aggressive, that as the health worker mentioned, and it was demoralizing them for staying there. So court also mentioned the same thing about the issues about the physical infrastructure in the screening area. So there were some temporary structures, while some were also had the permanent structure like Jamuna point of entry. So the issue in the temporary was that it was affected by rainfall, and some monkey would snatch and tear them, theft of the logistic and damage in the lights and display board. especially in terms of 3 number point of entry. They had both temporary and permanent, but they mentioned that there was lack of supervision in construction as per the standard construction design for the permanent. So they were not shifting to the permanent and still staying at the temporary health, health techs, and that was leading and that was causing more difficulties in terms of not meeting the infection control standard. So facility over there was quite nice in terms of that the development partners were supporting for ground crossing borders, and so those were equipped with health decks like outside of the main screening points. So there was gender or disability friendly toilets, drinking water, breastfeeding corner, or waiting chairs. And there was presence of tunnel to help direct the migrant flow, but it was quite in the inconvenient location. That means that it was quite far from the road networks or marketplace, and the exit area of the Heldex was quite close to the proximity of the temples or not in the road areas. Uh, about the limited awareness activities, so there were some pamphlets over there, but not actively disseminated due to the busyness of the staff, and no proactive or targeted awareness was there for the migrants. The police or the transport staff offered primary source of information after the arrival, not fully complying for the counseling. Um, about the theme three, migrant population responsiveness. So the migrants, they had the time pressure and fatigue after traveling from the long journey, and they had the fear of losing belongings and security concerns discouraging waiting. So screening takes approximately about 30 minutes, so that was leading impatience and frustration. So some migrants, they had no awareness and misinformation, especially about the purpose, the cost, or the importance of screening. They had lack of pre-arrival communication or outreach. And however, some had the mixed attitude engagement. So those who were educated or pre-informed, they were quite cooperative, and they had some kind of perceived risk, and the positive feedback was given by those migrants who already got the test results, and they found that it increased their awareness. So this one, like we also talked earlier before about that the migrants, they are um eloped by the auto drivers. They cross to the India side and carry their stuff, which it has been difficult for us, that one health worker mentioned about. And they were kind of like diverting their ways towards the health decks. So one of the migrants was unaware of about the screening. I mentioned that only stuff get checked, not the human body, only stuff like if there is a weapon or anything. One of the migrants mentioned that about staying at the high risk zone, and felt quite important or necessary to conduct testing. About the theme three, that is contextual factor. First one is monitoring and evaluation. So health worker mentioned that there was irregular supervision or infrequent field visits from the local, provincial, or federal level, and the reliance was mostly on online chats or phone calls, especially monitoring the data as well. They communicate in the WhatsApp, but then it's not so much frequent in terms of directly going to the field and finding out the issues. So the health worker lacked the formal or orientation or training. So one of the health worker here mentioned that I joined Point of Entry in June 2022. It has been 6 months already, and I have not received any. It would be okay if I had received, as I got hired here. So the person that she was finding difficult in terms of entering the data, and so she was learning from by doing her duty. There was no system for staff appraisal that one health worker mentioned. And but however, the positive side was there was review meetings, which was conducted by the local level municipality, and where the updates and national guideline diagnostic issues were discussed. About the political commitments and administrative barriers, so there was shift from municipal to provincial oversight, which reduced the local coordination and budget autonomy. And some administrative hurdles were there in terms of operating the point of entry, like the security staffs were frequently transferred, and there were some disruptions during the elections or festivals. There was lack of support from vehicle or hotel operator, as earlier mentioned as well. The limited budget for regular orientation and interagency coordination also lead to the difficulties in regularly conducting the testing. So one of the health worker mentioned that we must stay as a guard to convince them. The security personnel have dress and power. We, the health worker, cannot speak loudly. So the health worker feel quite hopeless for not able to convince the migrant population. Adaptation in the integrated screening system. So at that moment, there was COVID-19, and which enabled the testing in the integrated testing for COVID-19, malaria, and tuberculosis. But there were decreased cooperation due to the decrease in COVID-19 cases and having perception of lower transmission risk. And there were concerns over the RDT cross-reactivity, like with scrub typhus COVID-19. And some reporting gaps was over there in terms of like malaria testing report often not enter into official systems and rather reported in Google Sheets, risks, causing the risk in the data accuracy. So here it's a summary of what are the barriers and facilitators. So the barriers were the distant health techs, low political priority from the authorities or key sectors, gaps in training for the health worker and weak supervision, poor outreach, that is a minimal awareness among the migrants. There were staff shortages like inadequate HR for high migrant flow. Logistics from the NGOs was enabling the screening, supporting the role in supplies and setups. Risk perception from among the migrants was motivating to conduct the tests. There were 3 tiers of government which was involved for conducting the testing, as it was highly prioritized, especially by the federal government. The monthly reviews was there, which was conducted in the local municipalities, which was aiding the coordinations and feedback. Overall conclusion is, despite the progress in reducing imported cases and halting malaria transmission at the point of entry health decks, challenges remains in ensuring consistent and high quality implementation of malaria screening strategies. Role of cross-cutting non-health sector in health is crucial. This research point out the importance of local government in federal context. So cross-border malaria control initiatives should continually be adopted across globe to attain elimination. So the take-home message on the recommendations are from the 3 levels, from the people or the health worker, from system and overall organization. So for the health worker, there should be the proper communication strategy where they can learn, they can share their difficulties while working in the point of entry, about making more about how to get reported. So first one is reflection of the activities in EWP, that is annual work plan and budgeting of the local level or provincial level, where they can incorporate some activities like procurement of antigen or test kits and logistics, or enhance the comfort of migrant in arrival, including infrastructural upgrades and outreach activities as well. So within the system, if there can be some stable political commitment, there can be the the testing can be uplifted whenever there's some elections as well, or during the festivities. And in terms of automation, there should be effective monitoring and supervision and coaching, and improve coordination mechanism among the various sectors. There's some pictures. Thank you. Thank you to TDR Global Asia and all the audience here. I feel so glad to share my research. Thank you so much.
Thank you so much, Ms Aney Rijal. Let's have a round of applause to her virtually, because we have to admit that the research is very good and very great. Very great. We're very grateful to have her explaining to us. Oh, we already have people waiting in line for our Q&A. Are you ready, Miss Annie? Okay.
I'm
So
reading some of the questions.
yeah, so we have a few questions. We welcome your questions and insights. Please raise your hand to submit your questions and or use the chat box. We have someone raised the hand on the audience from Utsamani Cintiamena. Hello, Utsamani.
Hello, good morning everyone, and also good morning, Miss Aney. Maybe can I ask question to you regarding your research?
Yes, go on, go on.
Go ahead.
Okay, yeah, thank you so much and congratulations for your work. It's such amazing work. I have two questions for you. The first one is related to the motivation of traveler of getting tested. So, maybe I would ask about maybe any quantitative data. Do you have any data on how many traveler are not getting tested? I'm so curious, why do you think the most traveler don't skip testing? Because from your presentation, it seems that they need to go to the health test and get tested, and the numbers are increased each year. What do you think makes them follow that instructions? And then the second question is related about the positive cases of malaria that being detected at the border. Do you also have the quantitative data on how many positive malaria cases detected at the border? And also, what do you think testing at the border should be increased? If so, what do you think that would be the best strategy to improve malaria testing at the border? Maybe that's all for my question. Thank you.
Can I respond now?
Yeah, you can respond.
Okay. Thank you so much, Utsamani. Sorry if I pronounce it wrong. So thank you for the question. It's quite interesting in terms of the motivation. So firstly, I want to give some context upon so the migrant population, there is always there's not proper counseling from the police officers, as I mentioned earlier before, and when they don't have their own belongings, they often get missed from the testing area, and the health worker, they would be quite busier in entering those who enter to the health desk. So that's why we would not be fully sure about the quantitative data of how many migrants entering inside the border itself, and then how many migrants are missed from the borders. So I feel like if there can be the proper coordinating mechanism in terms of how many migrants enter inside, then we could identify okay, how many have entered inside and how many have just skipped the border post. So there's always some confusions among the police officials as well. Some are pilgrims as well. Some are just the business shopkeepers. So it's quite like it's very challenging to monitor how many migrants have come inside. So that's why I didn't mention here like how many migrants came inside like we only mentioned here about how many were tested, but we could not mention like among how many migrants the what testing was done. I want to talk about the another. I want to give another answer to another question. So there were altogether 10 malaria positive cases from the 3 point of entry Heldex, and which was reported from March 2021 until December 2022. But then, like per annually, it was just reported like 5 cases, which was like quite minimal. I think less than 0.5 among those who are tested in the border. Did I answer your question?
Yes, thank you so much for the
another question as well. Like, what are the strategy, right?
yes. What do you think about the strategy to increase the testing? Because like the number is, yeah, as you mentioned before, only 5.
Yeah. I mean, in terms of strategies, as I mentioned earlier, like if there can be effective infrastructure over there, like if there can be a proper way mechanisms of migrant being aware that they should be get tested over there, like if there some of the health worker mentioned like if there can be some community level awareness. So if they want to go to India for work, then they have to come back to Nepal and they should do testing. So if there can be proper mechanism for awareness and also proper coordination between the different actors, here I mentioned like the police officials and health worker, the transportation or the hotel operators, like they it seems like they are eloping, and we myself when we observed like they were quite more in hurry, like they they ha- the transportation worker, they feel like they will not get their money when the migrant go inside the testing area, and the migrant they feel like they will lose their belongings. So there is not proper coordination in terms of that. So if there can be a proper channel of communication, then that could be more effective.
Thank you for explaining. It's very clear. Thank you.
Thank you.
Thank you so much, Utsamani and Annie. If anyone have a round of questions live, perhaps you can raise your hand. And while we're waiting for another participant to ask the questions, we can see the questions from the chat box right now. There's 2 questions, one from NM. While screening for malaria, if migrant tested negative for malaria but tested positive for some other diseases such as TB, what was the protocol to record and screen instances of such imported disease?
So mostly in terms of recording, they take all the data, especially where they live, about overall locations, the contact details, and they test the TB, but they take to for confirmation, they take to the labs, the other health facility where they can confirm the TB cases when the malaria test positive is negative, and then after they confirm the test, the health worker they will contact to the migrant worker, and there will be cross contract tracing of those if they are positive. Did I answer the question?
Madam, if you have further questions to Annie's answers, feel free to reply on the chat box. So, next question is from AA Kusumadinata. May I ask, is malaria categorized as an extraordinary event in Nepal? And is there any influence on climate change? And how is the mitigation of local wisdom of the local government in accordance with modern knowledge? Thank you.
I could not understand the extraordinary event here. What does it mean?
In extraordinary event is in Indonesia when usually a malaria case happen, it categorizes as an outbreak.
I see. Okay. So there was one outbreak which was reported in 2018, but afterwards there's what we can find like in terms of climate change here is so the cases especially nowadays reported in the higher region of Nepal, like in the higher altitude these days. So that is quite that would be quite challenging for eliminating the malaria transmission. And so, as we can see in the data that the like 95.6% of cases are tested positive, which are from imported, which they categorize as imported malaria. But if it keeps on increasing, like the imported cases keeps on increasing, there is one research which has reported that it can increase the local foci malaria transmission as well. So I think that if it is not controlled properly, if the community-based testing and the border testing is not controlled, is not properly done, then we would soon have the chance of the local foci transmission. And one thing we cannot ignore the fact that many of the Nepali people, they go to India for work, especially in the seasonal basis. So I myself, being as a researcher, I feel like there is some level of loopholes on like how they themselves categorize the imported and indigenous cases. Like there's always chances of categorizing into imported because many people go to India. So yeah, okay, so this is imported. So that's why I feel like there should be proper mechanisms to keep the criteria on how to categorize the cases without delay.
Okay. So that is the answer for Aku Sumadinata. Perhaps if you have another questions or if follow-up questions, is there an you can put your questions on the chat below. And also there's two questions from Bubung in Sandoyo. Are there any mosquito repellent plants in Nepal? Like lavender in Indonesia? And is there a distribution of abate powder to kill mosquito larvae like in Indonesia?
I'm not sure about the repellent plant. I think there's mostly the repellent, the chemical-based repellent, but maybe it can be found in the indigenous communities.
Okay, so is there any distribution of abate to kill mosquito larvae in Nepal or?
Like there's the integrated vector management, which conducts the where they do this. Firstly, like there would be surveillance of the mosquitoes, and then identify like where there are more the malaria where there are more mosquito risks, and there would be the continuous vector control management in those regions. Like we have the microstratification every year, and so as I mentioned earlier as well, like in the Lumini and Sudirpasing province, there are like 16 high risk zone out of 22, which had a higher number of mosquito, like malaria causing mosquitoes. So there is some level of continuous uh, uh, activities in terms of controlling the larva populations.
I see. Oh, interesting. Oh yeah. Bubung, if you have any follow-up questions, please feel free to type your question in the chat room. Also, is there any more questions from the participants? Okay, I see that perhaps there's no more questions from the participant. For this session, Annie, can you have a little summary of what you think is important to highlight later on, as we know that malaria elimination is always processing? Do you have any words for perhaps anyone, stakeholders, researchers, anyone?
Yeah. So as reflected by Bubung, as the question by Bubung as well about the vector management. So I think there's some level of research that has been conducted among plants as well to control the malaria causing mosquitoes, and not just malaria, but we have nowadays there is endemicity of dengue as well. So the thing is that like this research should be conducted in a sense that it reflects the malaria endemic country situation scenarios of other Southeast Asia region as well. And what we're trying to say is that there's a frequent movement, and we cannot change how people are migrating from place to place. But what we as a researcher should learn is how we can identify the issues, the core issues that the migrant are facing, how the health worker are uh, dealing with the situations over there, and how the local level government are trying to enable the screening over there, because the border points are always like a political interest for the main national government, and if there cannot be proper coordination between the administrative sectors and the health sectors, then it is quite challenging to implement the interventions like these. Like because of COVID-19, we there was integrated screening, but if there is no threats, if the threat keeps on decreasing, then it's quite challenging to comply with the protocols on conducting the screening over there. So there should be some mechanisms to continue strengthening the screening facilities, but then also not so troubling the migrants as well, in terms of like they're coming from the long journeys. And so I feel like there should be the setting of the strategies where which can be same in the all scenarios, and so that there will not be the additional burden for both the health worker and also for the migrants. I think that's it for now.
Yeah, that's really great. Perhaps we are very grateful for you, Ms Aney Rijal, that you want to uh, share your important and grounded insights, especially from the ground of Nepal and India, of course. That today's your presentations gave us like clearer understanding of how malaria screening is being implemented on the point of entry in Nepal-India border, and the real world challenges faced by frontline health workers. And we heard how enabling factors happen as much as how multiple barriers happen, and it's really great. Ultimately, this study remind us that effective border health interventions rely not only on good protocols but also on commitments, a responsive system, and meaningful engagement with migrant communities also. So that we hope today's session sparks further dialogue and collaboration across the region as we work towards a malaria-free future. And that concludes our session for today. But before we close the sessions, perhaps we can take a little photo for a memory remembrance of this event. We have 146 participants with us today, which is quite a huge number, especially during this day. It's still a work day. Although perhaps some of you might have a very fancy weekend tomorrow. For everyone, please open your camera. We'll take a little photo. And so we saw a lot of participants from Indonesia, perhaps from India and Nepal also. Okay, so everyone, open your camera and smile. In three, two, one. Again, we have 6 page over here. The second page. Three, two, one. And three, two, one. Okay. So, before we close this event, before we close uh, this webinar, we also have a little announcement for everyone that needs an e-certificate. Or we prepare a certificate for you. So you might fill the form on the chat room. We already share you a form, a link to a Google form, and we will proceed your e-certificate as soon as possible. And once again, on behalf of TDR Global Asia, we thank you very much for your attendance and participation on this webinar. We thank you so much, Ms Aney Rijal, also for the lovely insight. We'll see you soon, perhaps, in Indonesia soon.
Thank you so much. Thank you so much, everyone, listening me.
Thank you so much also for everyone that
Thank you so
actively
much.
participating. Uh, that concludes our session for today. Have a great afternoon. Thank you, everyone. Bye-bye.
Bye bye.